and she will speak about prophylactic versus clinically driven antibiotics in comatose survivors of out-of-hospital cardiac arrest.
Dear Chairman, thank you for introduction. Dear ladies and gentlemen, as already said, I'm coming from University Medical Center of Ljubljana, Slovenia, and in the next few minutes I would like to present you the result of the study in which we compared prophylactic versus clinically driven antibiotics in comatose survivors of out-of-hospital cardiac arrest. In past decades, post-resuscitation management of comatose survivors of out-of-hospital cardiac arrest significantly improved. But despite of that, post-resuscitation systemic inflammatory response driven by ischemia, reperfusion injury, and also early onset of infection, especially pneumonia, can represent a significant challenge as it may lead to multi-organ dysfunction, prolonged mechanical ventilation, ICU stay, and also decreased survival. In past years, there was some publication regarding the use of prophylactic antibiotics in this group of patients, and they show us, they were retrogradic, show us that prophylactic antibiotics can or may reduce the early onset of pneumonia, but didn't, in one, the last one, didn't have any significant impact on ICU stay or survival of this patient, while the another one showed the improved survival in this group of patients if the antibiotics were given in the early phase during the first 7 days. But because there are so many unanswered questions and we don't have randomized trials investigating potential benefits of prophylactic antibiotics, we decided to explore this field, and we made research in which the hypothesis was that prophylactic antibiotics on admission decrease severity of post-resuscitation systemic inflammatory response by reducing the incidence of early post-resuscitation infection, especially pneumonia. So we designed a study that was single-centered, randomized, in which we screened consecutive survivors of out-of-hospital cardiac arrest admitted to Center of Intensive Internal Medicine between September 2030 and February 2050. Primary endpoints of the design were severity of post-resuscitation systemic inflammatory response, estimated or judged by the values of white blood cell count, C-reactive protein procalcitonin in the first week, and secondary endpoints you can read in the slide. Now, if you look at the flow chart, the 103 patients were assessed for eligibility. Among them, 43 were excluded. Some because they were dead on admission or no active treatment were decided on admission. One was candidate and received ECMO, and in 10 cases, logistic problem precluded bronchoscopy at admission. 13 patients had major tracheobronchial aspiration and received, after bronchoscopy for cleaning the pathways and taking samples for microbiology, received antibiotics. And from those who didn't have signs of major aspiration, bronchoscopy was performed. And during it, we made distal bronchial washing using 20 milliliters of sterile saline water. And if in that aspirate there was particles suggesting gastrical or oropharyngeal aspiration, we defined that as minor aspiration, and also these patients were excluded. So at the end, there was 60 patients randomized, either receiving prophylactic antibiotics, that being amoxicillin with clavulanic acid, 1.2 grams, 3 times daily IV, or clinically driven antibiotics. Now, administration of antibiotics in this group was at discretion of attending intensivist, but he had to take into account pre-existing criteria having 2 or more markers of infection from the field of inflammatory parameters, radiological signs, microbiological positive samples, and clinical signs. Admission criteria, resuscitation, pre-hospital resuscitation, and also initial hospital therapy, including PCI, immediate PCI, implementation of intra-aortic balloon pump, and therapeutic hypothermia were well matched between the groups. Now, regarding the antibiotic therapy, percentage of patients receiving antibiotic in prophylactic group was significantly higher in the mentioned, meaning prophylactic group comparing to those in clinically driven, but this was seen in the first 5 days. Afterwards, this significance was lost. Regarding the selection of antibiotics, the amoxicillin with clavulanic acids was the main antibiotic receiving in both groups, but the heterogeneity among selection was much bigger in clinically driven, especially from day 5. Further, C-reactive protein in the first 5 days in both groups, it progressively increased, but in prophylactic then stabilized and start to decrease, while in clinically driven, it just continued to increase till the day 6 when it reached statistical significant difference and afterwards decline. Regarding the white blood cell count, there was no difference in both groups, and in the regard of procalcitonin values, we can see that the values are significantly scattered and there is overlap between the groups. In the field of microbiological samplings, to all the patients, as I already told, there was performed distal bronchial washing, and the positive results were the same regarding the numbers in both groups. There was more positive mini-BAL on day 3 in clinically driven group, but afterwards, regarding the tracheobronchial aspirates from day 4 to 7, there is no significant difference, and also not in positive hemocultures during the first 7 days. Regarding the secondary endpoints, taking into account radiological signs of pneumonia, usage of vasopressor, duration of tracheal intubation, mechanical ventilation, ICU stay, ICU survival, or ICU survival with good neurological outcome, there was no difference. So in conclusion, I can say that with performance of bronchoscopy in this study, we can identify 28% of potential patients to aspirate. Although they were intubated already on the field, on the other questions, prophylactic antibiotics, we think, had no major impact on severity of post-resuscitation inflammatory response or on secondary endpoints. But our result must be validated from the view there is significant crossover to antibiotic treatment in clinically driven group. Thank you for attention.
Thank you very much. Very nice study. Are there questions?
One from me. What do you recommend? Would you prefer to recommend the systematic use of?
No, we are not doing that. We are not using.
Based on your results, of course.
On these results, we are still doing like we were doing before, taking all the criteria whether we think that patient is having infection, then we discuss and give antibiotics and see what the result of microbiological samples are, if there is any change in clinical and other criteria for infections. We are quite anxiously waiting the results of the multicentric a study that is being performed now in France.
Yes.
Uh,
Which is the Antarctic study.
Yes, yes. And if I'm correct, you are planning to recruit the needed number of the patient till the end of 2017.
That's fine, that's it. And in the Antarctic study, the design is to randomize patients without evidence of aspiration to receive either a placebo or a prophylactic antibiotherapy over the first 48 hours, and then to assess the rate of pneumonia in each group.
But may I now have a question for you?
Of course.
How do you exclude aspiration? Do you perform bronchoscopy to be sure that the...
No.
No.
Not systematic bronchoscopy.
Okay.
It's the clinical judgment of the team
Okay.
at time of admission and randomization,
And
based on information coming from the resuscitation characteristics and what is observed in the patient, looking at physical examination and early radiological examination.
Thank you.
Alan, do you think that what do you think is the major pathophysiological cause of pneumonia in this patient? Isn't it in the majority silent aspiration? So I would even question why we should differentiate between obvious and silent aspiration, because all are at increased risk for that.
I mean, probably the silent aspiration is the most important determinant, I agree. It's difficult to know if treating this complication is or not an important determinant of outcome in this patient. This is another question for you. Your opinion.
We run all the patients that aspirate with major or minor aspiration, as we define them, in parallel registry. And the end result showed no difference comparing to those that were randomized in secondary outcomes. This is the information we got from the study.
Just for me, in the room today, in your routine practice, what would you do? What do you do? Do you use a systematic antibiotherapy in all these patients? For those who do it, a minority of you are doing this. Okay, that's okay. Thank you.
Thank you.
Thank you very much.